Hello, welcome to this presentation on the overview of Canada's healthcare system. The presentation today will cover the key features of the healthcare system, the roles of the federal and the provincial territorial governments in healthcare, and I'll end the presentation with some points on how the healthcare system is financed. So I'm going to begin with some key features of the healthcare system, beginning with a bit of history of how the system evolved since the Second World War, about 75 years ago. So in the post-war push to create the welfare state, Canada saw increasing pressures for governments to increase their role in the healthcare system. This pressure began with individual provinces taking the lead to expand coverage, followed by federal initiatives to promote pan-Canadian adoption of these measures. So, for example, in 1948, the National Health Grants provided federal funding for certain hospitals in Canada. As far as hospital insurance is concerned, publicly funded hospital insurance began in Saskatchewan in 1947. And this was followed in 1958 by 50% federal cost sharing of hospital expenditures. So that meant that 50% of eligible hospital expenditures were covered by the federal government, and the other 50% was covered by the provinces and territories. As far as physician insurance is concerned, again, public coverage for physician services began in the province of Saskatchewan in 1962. And 50% federal cost sharing for physician services began in 1968. So by 1972, all the provinces and territories in Canada offered universal first-order coverage for hospital and physician services. In 1977, the federal approach to funding healthcare services changed. It moved from the open-ended 50-50 cost sharing that we had before to a lump sum block grant to the provinces and territories for healthcare. This was called Established Programs Financing. In 1984, the Canada Health Act was introduced by the federal parliament to address mounting concerns about user fees and extra billing. And user fees are simply fees that hospitals charge their patients. And extra billing occurs when physicians charge extra over and above what the provinces pay for their physician services. And the Canada Health Act, or the CHA, establishes criteria that the provinces and territories must meet in order to receive the full federal funding for healthcare through the Canada Health Transfer. In the early 1990s, we had slow economic growth in Canada, and this led to increasing fiscal pressures, which led to federal cuts in the growth in transfers to provinces and territories. This resulted in mounting public concerns about access to healthcare services and lengthy wait times for certain services. And these pressures led to federal reinvestment in federal healthcare, starting in 2000 through various accords between the federal and provincial territorial governments. And these accords were agreed to in 2000, 2003, and 2004. In addition to increased federal transfers to the provinces and territories, the Government of Canada also made targeted investments in primary health care, health information technology, medical equipment, and wait times. In 2017, the federal government and the provinces and territories agreed to a common statement of principles for shared health priorities in areas such as community care, i.e. home care services, and mental health and addiction services. And most recently, earlier this month, in February 2023, the federal government announced additional investments of more than $196 billion over 10 years to the provinces and territories to fund healthcare services. I'm going to talk about some key features of Canada's healthcare system today. The system is mostly under provincial territorial management. The system is predominantly publicly funded. About 70% of healthcare expenditures are funded publicly. The other 30% is funded privately. In Canada, we have universal first dollar coverage for hospital and physician services. So that means for these services, all Canadian residents do not pay out of pocket for these types of services. For other services, such as drugs, other professional services, such as those of dentists, continuing care services, such as home care services, and residential long-term care services, there is a mix of public programs and voluntary private insurance to pay for these services. And if individuals do not have private health insurance or public coverage for these services, then they will pay out of pocket for these services. And as far as delivery is concerned, it's a mix of public and private delivery for these services. And most of the health professionals in the system, such as doctors, dentists, are considered to be self-employed professionals, i.e. they're not employees of government. So I'm going to talk about a bit about healthcare delivery. As I mentioned, healthcare services are delivered by a range of providers, some of which are owned by governments, some of which are privately owned, either not-for-profit or for-profit organizations. So, for example, hospitals in Canada are either publicly owned by governments directly or also owned by private not-for-profit institutions. And hospitals are generally funded through global budgets based on historical spending. So, for example, if a hospital received $10 million last year, they'll receive $10 million again this year, plus a bit extra to cover increased costs. However, some jurisdictions, such as Ontario, are moving to funding based on the number of cases treated. And this type of system is called activity-based funding. Other healthcare institutions, such as home care providers, long-term care facilities, are again a mix of private for-profit, private not-for-profit, and public organizations. Physicians are mainly self-employed and generally work on a fee-for-service basis, i.e. they're paid based on the number of services that they provide to their patients. Although in some cases, alternate payment systems such as capitation or salary is used. And about 3/4 of payments to physicians are made on a fee-for-service basis. Unionized health professionals such as nurses bargain with their employers within broad frameworks set by the provincial territorial governments. Other health professionals such as dentists, physiotherapists, and so on operate as self-employed professionals. And now I'm going to talk about the roles of the various levels of government for healthcare in Canada. We have 3 levels of government in Canada: federal government, which is the national government, provinces and territories, and local governments such as municipalities. And in healthcare, 2 of those levels of government, the federal government and the provinces and territories, have responsibilities for healthcare. This chart shows the responsibilities of the federal government and the provinces and territories for healthcare. So, for example, the federal government administers the Canada Health Act, or the CHA. The federal government funds healthcare services by providing financial support to provinces and territories. The federal government also regulates market access to drugs and other medical devices. So the federal government, through Health Canada, regulates drugs, for instance. The federal government also regulates the prices for patented drugs. through an agency called the Patented Medicine Prices Review Board. And the federal government also provides or funds healthcare services for certain groups of people, such as members of the Canadian Armed Forces, inmates in federal penitentiaries, and some refugee protection claimants. Provinces and territories, on the other hand, deliver healthcare services for the residents. They manage the system in terms of the organization and governance of the system. They administer the provincial territorial health insurance plans. So they're the ones who pay physicians for the services provided. They're the ones who pay hospitals for the services that they provide to their residents. Provinces and territories also regulate the conduct of health professionals through the regulatory colleges that they set up. And they also manage capital expenditures for healthcare. So hospitals, so the location of hospitals are determined by provinces and territories. If a new hospital is required, then it's the provinces that determine where those hospitals are set up. And as you can see in the middle, we have joint responsibility or shared responsibilities between the federal government and the provinces and territories. For example, in funding healthcare, both the federal government funds healthcare and the provinces and territories as well. The same goes for health research. The federal government has an agency called the Canadian Institutes of Health Research, which funds health research. Many provinces have this similar organization. Both levels of government negotiate drug prices for the drug plans. Both levels of government support health promotion and health prevention measures. And both levels of government deliver services to First Nations and Inuit people. I mentioned the Canada Health Act, or the CHA, and this is the federal legislation that embodies the 5 principles of publicly funded hospital and physician coverage. And these principles are: 1, public administration. So that means each provincial territorial health insurance plan must be administered by a public body. In almost all cases, this is the Ministry of Health. 2, the plan must be comprehensive. This means that all medically necessary hospital and physician services must be covered by the public plan. 3, universality. This means that all eligible residents must be covered by the public plan. And in Canada, eligibility does not depend on citizenship. So that means all legal residents in Canada, whether citizens or not, are eligible for coverage. Portability means that coverage is maintained when a person travels outside his or her home province or territory. So, for example, when somebody goes on holidays to another province, that person retains coverage outside the province. And when the person moves permanently outside a province to another one, that person continues to receive coverage until that person is eligible for coverage in a new province or territory. And finally, the final condition, number 5, is accessibility. This means that there must be reasonable access to insured services, i.e. there can be no financial barriers to receiving coverage. In essence, this means that there can be no user fees for the medically necessary hospital physician services. And I'm going to talk a bit more about system governance. In many jurisdictions, the publicly funded hospital and continuing care services are planned and delivered by health authorities created by the provinces and territories. So that means, for example, in a certain area, a certain province, the provincial government has delegated the day-to-day management of these services to a health authority. In all cases, funding for physician services and drug services remain the direct responsibility of PT governments. So this means that as a result, health authorities have only limited control over key cost drivers of the healthcare system. They can control hospital expenditures, but they cannot control physician expenditures or drug costs. Those responsibilities remain at the purview of the government. And this chart, this map, shows how the system operates in Canada today. In recent years, there has been a trend towards consolidating the administration of healthcare delivery, i.e. into a smaller number of health authorities. So for example, in the Western province of British Columbia, there are now 5 regional health authorities. About 20 years ago, there used to be 52 regional health authorities in that province. So you can see the number shrinking to a more manageable number. And this was done to create more economies of scale in the delivery of healthcare services and to reduce the administrative costs of running regional health authorities. As you can see, Quebec is the only province or territory in Canada that still has a relatively large number of these health authorities. They have 22, but most of the other provinces and territories have much smaller numbers of these health authorities. I'm going to talk a bit about the regulation of healthcare providers. It is the provinces and territories that are responsible for managing the quality of healthcare that are delivered to the residents. However, they do not directly regulate the conduct of healthcare providers. The accreditation of healthcare facilities and organizations is carried out by an independent body called Accreditation Canada. And in most provinces and territories, it is compulsory that healthcare facilities such as hospitals be accredited by this body. Provinces and territories provide the framework for the self-regulation of health professionals. So provinces and territories do not regulate health professionals such as physicians and nurses directly. They do it indirectly through regulatory colleges. So for example, if a patient has a complaint about his or her physician, they would take it to the regulatory college and not to the provinces and territories directly. So for example, in Ontario, there is the College of Physicians and Surgeons of Ontario, which regulates the conduct of physicians. And if patients have complaints, they would take it to this body. Most provinces have also created healthcare quality organizations that monitor and report on the quality of healthcare services. For example, Quebec has a Health and Social Services Commissioner that reports on the quality of healthcare delivered in Quebec. And finally, I'm going to talk about a bit about health system financing, how the system is funded. So as I mentioned briefly, about 70% of health expenditures are funded by governments, i.e. 70% are publicly funded, 30% of expenditures is privately funded. Funding for healthcare is provided by the provincial territorial governments, the federal government, and through the general public, i.e. through private insurance coverage, or else through out-of-pocket spending. The revenues for the 70% that is publicly funded comes from general taxation revenue sources, such as personal income taxes, consumption taxes, such as sales taxes and corporate income taxes. In Canada, we generally do not have taxes earmarked for health expenditures. Private funding for healthcare comes from 2 main sources: out-of-pocket payments and private health insurance. Out-of-pocket payments are required by individuals if neither the public health insurance plan nor the private insurance coverage fully pays for the services. So for example, for drug expenditures, for instance, some people have public coverage for drugs. Some people have private coverage for drugs. if the public plan nor the private plan fully covers your drug costs, then you would have to pay the remainder out of pocket. And out-of-pocket costs account for about 14% of health expenditures in Canada. Private health insurance accounts for about 11% of health expenditures. And in Canada, supplementary private health insurance is often offered by employers to their employees as a fringe benefit. And private health insurance coverage covers those services that are not publicly funded in Canada. And this chart shows the various components of healthcare expenditures in Canada today. As you can see, hospitals account for about 1/4 of total health expenditures. And drugs make up about 14% of expenditures, and physician services make up about 14% of expenditures as well. So in total, these three big items, hospitals, drugs, and physicians, make up more than half of total health expenditures in Canada today. And I mentioned the 70-30% split between public funding and private funding for healthcare services. That is true in general. However, if you look at specific categories of health expenditures, there is quite a bit of variation. So for example, for hospitals and physicians, more than 90% of their expenditures are covered through public sources, and less than 10% of physicians and hospital services are paid for through private sources. On the other hand, you can see that almost 90% of expenditures for other professionals, such as dentists, optometrists, physiotherapists, and so on, are privately funded. And that is a reflection of the fact that these services are outside the publicly funded system. So Canadians pay principally out of pocket or use private insurance to cover these expenditures. The same goes for drug expenditures. About 2/3 of drug expenditures in Canada today are privately funded, and only about 1/3 is publicly funded. And I'll end with Health Canada's website, and this is where you can find further information on the healthcare system in Canada today. Thank you.